Thank you, everybody, for being here. This is the last seminar of the Precision Health Seminar Series. It is organized by the Education and Training Work Group of the Precision Health Initiative. My name is Veronica Berrocal, and I am an associate professor in the Department of Biostatistics in the School of Public Health, and I co-lead the Precision and the Education and Training Work Group together with Vicky Erlingrod, who is a professor and associate dean for research in pharmacy in the College of Pharmacy. So just before we hear about this precision health research by Helen Kales, I just wanted to give you a few words about precision health. So precision health is an initiative that was launched in January with multiple goals. One is to foster and enable research, interdisciplinary research in precision health at the University of Michigan by developing tools and resources that can facilitate this type of research. We also are interested in supporting implementation of findings into real-life healthcare. And our work group of education and training is dedicated to promote education and training events. So as I said, this is the last seminar of the Precision Health Seminar Series. We will reconvene and start a new series in the fall semester. And during the summer, we will have a day-long symposium that will take place on May 29. There's going to be several talks during the symposium, including a talk by Consuelo Wilkins from Vanderbilt and Gonzalo Becasis, who is split between University of Michigan and Regeneron. We'll also have a poster session, a lot of possibility for networking, and there will be also discussions. So we hope to see you there, and you can find more information about the Precision Health Symposium on the Precision Health Initiative website. So the plan for today is to have the seminar speaker give a presentation and then have a Q&A after her talk. So today's speaker is Dr. Helen Kales, who's professor of psychiatry here at the University of Michigan and also research investigator in the Center for Clinical Management Research in the VA in Ann Arbor Health System. She has published over 120 published peer-reviewed papers, and her research has been supported by federal funds since 2004. I don't know if I should say that, but we're set to know that in July 2019, Dr. Kales will be leaving University of Michigan and become the chair of psychiatry and the Joe Tupin Endowed Professor at University of California, Davis.
Thank you, Veronica. I think Veronica mentioned I'm a geriatric psychiatrist, and for those of you who don't know what that is, I am a psychiatrist who obtained additional fellowship training in the care of older adults. It's sort of at the intersection of medicine, neurology, and psychiatry. And a lot of what I do is see patients with dementia. And so as a researcher, much of my research also focuses on that area. So just briefly to acknowledge some of the research that has underwritten this work. This is research both from the National Institute of Mental Health as well as the National Institute of Nursing Research. And then I also wear a hat at the Veterans Administration and have VA funding. So today we're going to take a brief tour through one of the biggest problems that we see in dementia care, which is that of behavioral and psychological symptoms of dementia. We'll talk a little bit about the consequences that people face when dealing with these symptoms and the current sort of real-world treatment that people get right now. We'll talk about non-pharmacologic strategies, that is non-drug strategies, and then segue into two approaches we've developed here at University of Michigan, which relate to both personalized medicine and precision health. So I want to start briefly with a real-life case. Name has been changed, but Mr. Johnson is an 88-year-old man who has moderate dementia, and he's living in a long-term care facility, AKA a nursing home. And he has medical problems that include arthritis, high blood pressure, and diabetes. He's also had several falls in the past year, and you may know that nursing homes worry a lot about falls, so they're concerned about that. But for our interest, what happens one weekend is that the nursing staff call the doctor on call, who could be me or one of my colleagues, and say that Mr. Johnson is agitated and they need something to calm him down. And they specifically ask, as sometimes nursing staff do, for risperidone, which is an antipsychotic. So what happens is the doctor that answers the call is concerned about the side effects of antipsychotics, and we'll talk about that a little bit later, and decides that instead of starting him on the risperidone, they're going to start him on something called gabapentin. The other name for that is Neurontin. And that's a very sedating drug, and they decide to put him on that and that they will increase his dose over 2 weeks' time. So fast forward 1 week later, Mr. Johnson is still agitated at times, maybe a little less, but now he's more confused. And so the staff hold a team meeting, and at the next team meeting, they assert that his dementia is progressing, and they suggest that maybe the unit social worker should talk to the family about moving him to a higher level of care within the facility. So this is a fairly common scenario that occurs probably every day in the United States, and we'll sort of set the stage, and we'll come back to Mr. Johnson a bit later. So dementia, as you probably know, is a devastating syndrome. It's not caused by one illness, but can be caused by many illnesses. Here in the United States, Alzheimer's disease is the most common underlying cause. It currently affects about 5 million people in the United States, and as the population ages, that number is expected to increase to 16 million by 2050. Most people with dementia are actually cared for in the home, and so there's about 15 million family dementia caregivers in the United States, often unpaid, often untrained. And right now, there's no cure for dementia. So all we have are some symptomatic treatments which may help memory a little bit, but they don't cure the underlying cause. And while we think of memory problems as the hallmark, actually it's the non-memory or non-cognitive problems that tend to color the everyday course of dementia. And these symptoms, which I'll talk a bit more about in a minute, are nearly universal. So in a number of studies, it's been found that almost 100% of people with dementia have these behavioral and psychological symptoms that occur at some point in the illness course. And it doesn't matter what type of dementia they have, whether it's Alzheimer's or vascular, these symptoms can occur. And they often dominate the disease course. So here on the side of the slide, and I have a pointer here, are some of the behavioral and psychological symptoms we see. And many of these look like syndromes that we see in earlier life. So we're familiar with depression and anxiety. Apathy is something that's often mistaken for depression. It looks kind of similar, but people with apathy could be said to just not care. They're sort of amotivated, it's hard to get them started, but it's not depression. Psychosis is another one we see, agitation, aggression, and I say and many more because some of these don't fit neatly into these nice diagnostic categories. Some of the things we see in dementia are things like wandering or hoarding objects or yelling or spitting or sexual inappropriateness. And so there's many things that caregivers, whether they're a family member or a staff caregiver, are dealing with. And actually some of the most bothersome are actually not sort of diagnostic entities at all, but things like asking the same question over and over again. So as you see, they don't necessarily fit neatly into a diagnostic category, nor are they medication targets. But we know that these symptoms lead to multiple problems. One is that people that have them have greater functional impairment. So at any dementia stage, if you add a behavioral problem, it tends to decrease the function or the ability of the person to do their activities of daily living. They also worsen quality of life, and that's both for the person with dementia as well as their caregiver. They do lead to excess morbidity and hospitalization. So one of the things we've shown in our research is that behaviors often prevent people from getting adequate outpatient care. So they go to the emergency room for things that ordinarily would be managed in the outpatient arena. We also know that they're associated with earlier nursing home placement, and that's for a couple reasons. One is caregiver burden. As caregivers become more and more burdened, they may finally say, you know what, I can't take care of dad at home anymore. We're going to place him in a nursing home. And so again, these behaviors are what I always tell my families, it's not your memory that puts you into a nursing home, it's behavior and function, right? They're a major source of caregiver burden, and we often find that caregivers, especially family caregivers, are sandwiched. So they have their children on one end, they may have a mom or dad or another relative, and they're trying to work at the same time. So they may have to take time off work, they lose family income. One study estimated, and this is about a decade ago, so it's even more now, $10,000 a year in additional care costs due to behavior. In long-term care, behaviors are associated with decreased quality of care. They're associated with staff burnout, which is very important because one study found that in long-term care, caregivers turn over at a rate of several times a year. So you train somebody today, and 3 to 4 months later, they may be gone, and you have a new person in their place. And so that burnout and injury that occurs because of these behaviors is really critical. We also think they're associated with a shorter time to severe dementia, and in some studies, they seem to accelerate mortality. So as a colleague of mine says, behaviors are bad. They have bad outcomes. So this symposium is on precision medicine, and just some brief definitions as I understand them to orient us. Personalized medicine focuses on patients based on their own individual characteristics. Precision medicine focuses on identifying treatment approaches that will be effective for which certain patient. So related but not the same. And what we can say very readily is that current dementia care is neither personalized nor precise. So, as I said, we don't have a cure for dementia, so the current focus mostly is on day-to-day management of behavior and function. And what happens in the current real world is that most of this treatment, and I'm going to put that in little quotes, is centered on medicating or sedating people with dementia. And so you see, this is a fairly typical picture of somebody you might see in a nursing home if you've ever been one, but he's sort of got his head down, he might be snoozing, very common. And we know that the vast majority of people in nursing homes are on psychiatric medications. So once you get in a nursing home, it's very likely, even if you've never been on something in your life, you're going to get put on a psychiatric medication. So let's think about how that contrasts with what I would call physical symptoms. Now, know that it's all one brain, it's all one body, they're all coming from the brain, but we dichotomize these in treatment. So let's say a family caregiver is dealing with a physical symptom. The dad has shortness of breath. So they go to the doctor and they tell him that, and the doctor says, oh, okay, I got this. I'll write for an antibiotic right now. He's got pneumonia. Now, is that appropriate care? No, because how do we know that shortness of breath is coming from a pneumonia unless we do a history of physical and some lab work? There are about 100 causes, and you don't have to read this, but this is a schema that people would use in internal medicine to work up shortness of breath. And you can see that there's many causes of shortness of breath. So you could have a clot that's in your lung that's blocking your ability to breathe. You could have cardiac heart failure. You could have anemia. I could go on and on and on. There's about 100 causes of shortness of breath. So a doctor that's working this up has to do an investigation and figure out exactly what's going on. Conversely, we have a caregiver dealing with a behavior, and they say, Joe is agitated, like in our example. I need something to calm Joe down. Or if they're really prescriptive, as some of our nurses are, they'll say, I need Risperdal 0.5 milligrams twice a day. And often the response is, well, I'll write for that right now. So can you see the contrast between how we work one up and how we work the other up? And so I would put to you that we don't really have an algorithm currently, as I showed you in internal medicine for shortness of breath. This is our current algorithm. So we have agitation, and that leads directly to a prescription without any assessment of what's going on, what could be happening, person-centeredness, precision, personalization, and so forth. So our current treatment for behavioral symptoms actually goes back to the 1950s, and this is a real ad from a journal, the American Journal of Psychiatry. And what it says in small print is, what are we going to do about Pop? And Pop is agitated because he has dementia, and he's swinging that cane. And back in the 50s, the answer was, we're going to give him Thorazine, which is a very powerful antipsychotic. Well, I would say to you, our treatment is not that different now, even though we're in a new century. We're still giving antipsychotics. And in most cases, these medications don't actually treat the underlying problem, but we're just sedating the person so we don't hear about it. And these medications are associated with significant side effects, including mortality. We've done some of this work at University of Michigan. And how many here are familiar with something called the number needed to harm? Anybody here? So the number needed to harm is the number of people you need to treat to get one death. And so you want that number needed to harm to be as big as possible. You want to be able to treat a lot of people without causing any deaths. And what you can see here is for antidepressants, the number needed to harm, the antidepressant is the reference value, but for the antipsychotics, the number needed to harm ranges from 8 to about 20 or 30. So that's a small number. You only need to treat about 10 to 20 to 30 people to get one death. We also included another medication, which is called valproic acid. It's a mood stabilizer, and the number needed to harm is only 20 there. So these medications are associated with a lot of side effects. That's not to say I don't use them in practice, and I'll talk a little bit later about specific occasions when we use them, because it's always a risk-benefit balance, but we have to be realistic that there are significant side effects associated with them. We know that there have been programs in the United States to decrease antipsychotic use. The Center for Medicaid and Medicare has had a program to reduce antipsychotic use. But one of the things that we found in our research is that that means that they have only shifted that antipsychotic use to other drugs. And what are some of those other drugs? Well, they include drugs like benzodiazepines, which are tranquilizers like Ativan, Restoril, Valium. Those drugs are fairly toxic for older people, so that's actually not a good substitution. And they've really increased this, right here is the orange line, the group of what we call mood stabilizers. And that specifically is that drug called gabapentin or Neurontin. So a lot of people are using that. We've also had reports from the field, and we're looking at this actively, that people are using a lot of things like Benadryl, Atarax, which is actually a drug for itching, but it sedates people. And there's a new drug you may have seen advertised on TV called Nuedexta, which is for a very rare condition, which is called pathological laughing and crying. It comes from having a stroke. But what happened is the drug companies went in and urged people to also use it for dementia, and this is off-label use. And so we've seen an increase in this Nuedexta. And the Nuedexta is a combination of dextromethorphan, which is basically cough medicine, and something that increases its uptake in the brain. So it's basically fancy cough syrup. It's very sedating, and we've seen an increase in that as well. So all these efforts to reduce antipsychotic use have basically just shifted them over to other agents. So one of the things we've been thinking a lot about, and I'll unpack this for you, it's kind of a complicated model, but some colleagues and I devised a model to help people think about behavior and underlying causes. At the basis of behavior is neurodegeneration. So you have a dementia that's causing a disruption of brain circuits, and that itself can lead to symptoms. Or in many cases, what it leads to is people are more vulnerable to triggers. So the dementia causes a situation where certain triggers in the environment or with other people may create a behavior more readily than they would have before the person developed dementia. And we divided these into 3 categories: factors within the person, factors within the caregiver, and factors within the environment. So let's start with the person. How could that trigger behavior? Well, let's think about pain. If someone with dementia has pain and they can't communicate that they have pain, that might come out as what we see as agitation, right? And so if we see agitation and say, oh, okay, I'm gonna put them on a sedating drug, have we treated the pain? No, we've just made them sleepy. They still have the pain. So as you see, we're not actually dealing with the underlying cause, we're just sort of covering it over. Similarly, people with dementia may develop acute medical illnesses. One that's very common in my patients is urinary tract infection. And one of the first symptoms we might see of a urinary tract infection for those of us who've had one is urgency or frequency, having to go to the bathroom all the time. Someone with dementia probably is not going to express that. Instead, they may have hallucinations or they may look agitated. So again, if we say, oh, we'll just sedate them, they still have the infection. So what about caregivers? Why is that here? Well, one of the things that research has found is that caregivers and people with dementia are in close quarters, 24 hours a day, right? And their moods affect each other. There's a certain mirroring that goes on. So if you have a depressed, distressed caregiver, that tends to get mirrored in the person with dementia. Also, people who are caregivers often are not trained, so they don't understand sometimes that behaviors are not being done volitionally. They're not being done on purpose to make people upset. And so there can be this dynamic set up where a caregiver gets frustrated, doesn't understand where behaviors are coming from, starts yelling at the person with dementia, scolding them, and then the behaviors amplify. So training caregivers is a big part of it. And lastly, environment. It's often overlooked. How many here have ever been in a nursing home? Was it pleasant? No. So think about environment. Think about how you would feel. I once walked into a nursing home and there was a woman in what we call a jerry chair, which are those chairs for older people, and it was cranked up at an angle so she couldn't get out. And she was yelling, help, help, and everybody was just ignoring her. And I sort of tried to look around from her perspective. And as I looked around, there was nothing on the walls, there was nobody to talk to, and she was strapped in a chair. So yelling help in that situation is probably pretty rational, something we might do if we were strapped in a chair. And so thinking about environment and the lack of activity or structure or things to do. Now, many times places have things to do. I once went to a facility where they were running a group and they were basically asking people question after question, and it was really boring. And so people tried to leave the group. What did they do? They grabbed them and forced them back in. So I'm not saying, they're not doing the best they can with those resources, but that's not an activity that was holding people's attention. And so we'll talk in a little bit about how you tailor things and personalize things to people's interests. So given what I've been talking about, I would put forth that how we currently treat behaviors doesn't make a lot of sense. We have this brain disease that's leading to behavior, probably increasing some of the triggers in this triangle, and yet we're just trying to medicate it and sedate it. And it really doesn't make a lot of sense. So many people have been researching non-drug strategies. And most expert bodies recognize these are first-line approaches, and yet they're not implemented in day-to-day settings. They're better stated as non-pharmacologic is kind of like saying somebody is a non-man or non-woman. It's kind of saying what something isn't. They're better stated as eco-biopsychosocial, so they're kind of trying to look at that triad that I talked about. And why haven't they been implemented? Well, most people aren't trained. They don't know how to implement these. They take more time. So right now in the medical chart, I can go in and with our electronic medical record in a minute or two, I can put in a prescription, right? That's pretty easy. But doing these interventions takes time. Now in the long run, I would argue that you save yourself a lot of time. But again, we have to think about what the provider sitting in an office is thinking. There's also so many interventions. We hear about acupuncture and music therapy and things like reminiscence. What works and what doesn't, and what should we use? We know that these interventions work. There was a large meta-analysis where they took all the studies that had been done in this area, and they actually found that the effect size, how well things work, was bigger for these non-drug interventions than for any of our psychiatric medications, and also bigger for any of our cognitive medications in dementia, so things that help the memory. And yet again, they're not implemented. Now, most of these interventions, what do? To just unpack them for you. I told you a bit about triggers. They teach caregivers to spot triggers and how to manage them. They teach them how to increase activity for people with dementia, how to communicate better. Now, it's very easy for me to sit up here and say, talk calmly and do this and do that. And I have 3 teenagers, and I know that's easier said than done. But training people in communication can be very effective so that they're playing the role of that caregiver, and then if they need to step out and vent or talk to a friend, they can do it in that setting. We also want to enhance the environment and simplify tasks. Sometimes caregivers are telling somebody to do more than they can do at that stage of dementia. So how, with all that said, do we improve personalization and precision? We've thought a lot about it. And we really think that the key is to use technology, to use packaging, to make it nice for people and to help them to understand it, and innovation. So there's, we can do it, Beyonce says. So in 2011, what we did in my program was we held a national meeting of experts in dementia care, and we met all day, actually, at the Detroit airport to think about how we could do all these things, integrate caregivers, use something across settings, reduce knee-jerk medication use, and integrate the use of medications when we needed it. And we recognized that we need to package these non-pharmacologic approaches for people. And what we came up with was called the DICE approach. The D stands for describing the behavior. So most often we get such an incomplete description of a behavior. We say Joe is agitated, but that could mean any of 100 different things. Joe could be throwing things. Joe could be twiddling his thumbs. He could be, hoarding things or wandering. We just don't know when somebody says agitated what they mean. So we want to have that full picture. After we get that, we want to think like a detective and investigate. What could be causing what we're seeing? We need to think about what could the person be contributing, the caregiver, and the environment. And then C stands for create, and that is creating something in collaboration with anybody who's managing the person with dementia. We want to come up with some low-hanging fruit, simple, these aren't rocket science solutions. And then lastly, we want to evaluate. We want to see how they work. So I'll play this out with Mr. Johnson. So I told you about him. I told you what led up to that prescription he got, but what if it went a little differently? So describe. We want this full and accurate description of the behavior. Again, shortness of breath. If I went in and said I had shortness of breath, my doctor would say, when did it start? What time of day is it occurring? Is it what makes it better? What makes it worse? There would be a whole bunch of questions that went along with that. So in this, we need to know what exactly is going on when we say Joe is agitated. And what we tell our caregivers is play it back to us like you're telling us about a movie. And we often give them the example of the end of The Wizard of Oz. So at the end of The Wizard of Oz, as you all know, the witch dies. But if you told somebody that, they really wouldn't have an idea about what's going on. So we want that full picture of exactly how that happened. Dorothy trying to put out the scarecrow's fire and how she threw the water and how the witch melted. We want to know who, when, where, and what. So for Mr. Johnson, we learned that agitation is actually resistance to care when they're trying to give him daily baths. So they call that agitation, but it's something very specific. It's mostly with female staff. And from the staff's perspective, they're exasperated with him. The particular staff member says, he's doing this to just make me upset, get on my nerves. She responds to his resistance with frustration and anger. And they find that the baths are actually given not in any structured way or routine way, but they're sort of given when staff can do them. So it could be in the morning one day, it could be in the afternoon the next. Next, we go to investigate. So thinking like a detective, looking for triggers from one of those three categories. And we want to think about several areas that would be commonly sort of culprits. Pain is one. We teach our caregivers to look for nonverbal signs. And so that could include holding or rubbing a part of the body, groaning or moaning, pushing somebody away when they're touched. We also want to look for constipation. That could be occurring. And so that could be pain when you're touching the person's stomach, or they're not eating as much because they're so full. We want to look for things like urinary tract infection or recent changes in medication. So often people with dementia are put on different medications, and we want to know if there's been any change recently that could be causing problems. We also want to look at the caregiver factors we've been talking about. Could they be feeling stressed, anxious, and depressed themselves, offering too many choices? And then the environment, what's going on there? So for Mr. Johnson, we learned he's had no prior psychiatric history. He's hard of hearing, and he often forgets to wear his hearing aids, so that's important, and we'll come back to it later. He's also noted to rub his right shoulder during the doctor's exam and has reduced range of motion, so he can't really move his arm around the joint as well as we'd like him to do. When we talk to the staff, again, they're frustrated. They don't have a good understanding about behavior and how that actually comes from the brain disease. And they have this idea, which is very common in facilities, and it comes from the top, unfortunately, that they have to rigidly adhere to schedules and rules, and it's hard to deviate from them. Lastly, in the environment, he has a lack of structure. We have this no lead up to baths, and this is very common in facilities. How would you like it if somebody just grabbed you by the arm and said, "You're taking a bath now," right? None of us would really enjoy that. And so could there be more of sort of a lead up to having a bath? So what do we do with CREATE? We think of 6 general strategies for people, and this includes managing physical problems. So we want to look at anything that was identified in the investigate stage as a physical issue, like his right shoulder pain. We want to educate family or staff. We want to look at communication. We also want to create meaningful and tailored activities. And does that have to be complicated? Not at all. There have been people, for example, one gentleman we worked with was a carpenter. And so you create that person an activity board where he could turn switches on and off or open and close things. And that could keep him busy for an hour or so. And that's an hour of time that the caregiver had then to do things. We also want to simplify tasks for them. So if they can only do 3 steps, you don't want to give them 5. And then lastly, ensure that the environment is safe. So if wandering's an issue, or make sure that there are no weapons about or poisons around or things that could be gotten into. So for Mr. Johnson, we want to rule out medical issues. We want to ensure that he has routine hearing aid use. When people don't use hearing aids, they miss most of the conversation, and it's jarring to them then when they're led to a bath or they didn't hear what was going to go on. We also know that hearing problems are associated actually with the development of dementia, and we're learning more about why that is. We maybe can talk a little about it in the questions if people are interested. And then we want the physician to assess for that right shoulder pain. And maybe they find that it's a rotator cuff tear, and if that's the case, then maybe we need to treat that with a standing dose of pain medications. Our folks with dementia are often given as-needed medications, and what happens there is they don't know to ask for them, so they don't get them. We might also want to use non-medical strategies like heat or physical therapy. For the staff, we want to educate them about behaviors coming from what we call a broken brain, talking about communication, and importantly, we want to relax the rules. So baths don't have to occur every day. We can do a sponge bath, we can skip days, and then when we do have a bath, maybe since he's had trouble with female staff members, we could consider using a male staff member to see if that goes better. In the environment, sometimes what we do is we create a lead up to bath, so steaming the bathroom and kind of having the person see that it's sort of warm and pleasant. Might play sort of spa-like music, if the person liked that. And sometimes we might give a candy reward for a successful bath, all kind of reinforcing that this is a pleasant thing and not a punishment. We need to make sure to evaluate. So this is something that might be used in a facility. It's just a list of behaviors and the severity of the behaviors. But we can even use something, simpler for family members. And this is just to rate on a scale of 0 to 4 the severity and frequency, so that before we do an intervention, we have a baseline, and then a week or two later, we have how that worked. We also want to ask, what was the impact qualitatively on anything that we did? Were there any approaches that staff were resistant to trying, and why? What worked, what didn't work? And sometimes there could even be side effects of non-pharmacologic interventions. For example, maybe we try a male staff member and the behavior gets worse. So, you want to kind of note that as you're going. What about medications? I mentioned this before. Medications are used frequently in dementia. It's all off-label use, so there's no medication that is approved for use in dementia. We use them all off-label. That's not necessarily a bad thing, but we always want to assess the risks and the benefits, and you always want the benefits to be greater than the risks. So there's 3 cases in the DICE approach where we use medications first line. The first would be serious depression. That could be with or without suicidality. The second would be aggression with risk of harm to self or others. So when somebody's very aggressive, we're not going to be able to do a description and an investigation. So we may need to get them calm to the point where we can do that investigation and later take those medications away. And then lastly, we use medications where there's psychosis with harm. Now you might say, Dr. Kales, isn't there always harm with psychosis? And actually there isn't. So some people have hallucinations that we call benign. And I always give the example of a patient I had that the family came in and they said, Dr. Kales, you have to do something. He's hallucinating. It's really upsetting us. He's never had this before. And so I asked the gentleman, well, what are you seeing? And he said, well, have you ever been to Bronner's before? And I was like, oh, you mean the Christmas place up north? And he said, yes, I'm seeing displays of Santas and Christmas ornaments. And so I said to him, well, how do you feel about that? Are you scared? No, it's really pleasant. So I would never give somebody a medication for something like that, because in all actuality, in a week or so, it's probably going to go away on its own. So again, risks always have to be considered in consequence with benefits. We also should say that there are some people who have serious mental illness who come to late life and develop dementia. We would never say stop their medications because they develop dementia. What we may need to do is look at their regimen and say, can it be decreased or consolidated in a way so that they have the least amount of side effects. So the goal of the DICE approach is to decrease this sort of knee-jerk use of medication, which causes a worsening of symptoms. It also ignores underlying causes. It's inherently not personalized or precise. It causes unnecessary sedation, which then in turn causes things like falls, Parkinsonism, where the person almost appears to have Parkinson's disease, or in some cases with the benzodiazepines like Ativan, actually makes their memory worse, which is not what you want in dementia. We also have worsened quality of life associated with the medications, and like I said before, mortality. So we really want to also expand our consideration of medications to things like pain medications, antibiotics, things that could help people not be constipated. So I have that there. So here we have, again, the DICE approach. We could consider it in the D step, where we're trying to do this workup. Also in the I step, you could think about a person being aggressive and not allowing a blood draw or giving us a urine sample. In the create step, we would use it if there were one of those 3 conditions: depression, psychosis, or aggression with risk. And then in the evaluate stage, we always need to think about, did it work? Were there side effects? And at what point can we taper and discontinue it? We did a study a number of years ago in the VA and found that a number of veterans were continued on these medications for years and years, sometimes without ever being reassessed. They were started in the hospital. And so we always want to think about, can we get rid of these? So we've packaged these approaches by DICE, but as you can see, even in me telling you about it, it's taken a while. So how do we deliver it? So one of the things we've been doing in our program is we've been giving trainings throughout the state. So far, we have given 3 trainings throughout the state and have trained over 180 people. We've also given a training in Wisconsin where we've trained over 120 people, and those have gone very, very well. We've also developed a DICE manual, which is meant for both family and staff caregivers and is available on Amazon. And what people found the most helpful in these trainings were that we had workshops and we did problem solving together. People actually brought their own stories to the workshops where we went through them and we went through the DICE approach and helped them think through solutions. We gave them the book and handouts to take home, and they felt like the framework was really understandable. We also have a DICE website that is coming soon. Again, we're sort of thinking about how do we disseminate this? And so hopefully in a couple weeks this will be out. The website is meant for caregivers. It has about 9 modules that people train with, and then it has at the end of it, as you can see at the bottom here, what we call e-simulations. And these are cases that people can work through and get kind of guidance on how we would approach the case. So that will be coming soon. Lastly, I just want to talk about another way that we've implemented DICE, and this is thinking about people that don't have the time to use a website or feel too stressed to even do any training. And this is called the We Care Advisor. The We Care Advisor contains the DICE approach. It's web-based, and it also contains a comprehensive caregiver survival guide, which is meant to be, when we did about a year of qualitative research with caregivers, they told us that the internet to them is almost like the Wild West. They don't know what's vetted, what's good, what should they trust, and they don't want to spend their very little free time looking for things. And so we tried to put all of the information we could think of in one place. We also heard from caregivers that it's hard to keep going on a day-to-day basis, and so we gave them a daily supportive message in this tool. We then added personalization and precision by having a peer navigator lead them through the tool, and this peer navigator is keyed to that person's race and gender and age. And then in the tool, they use the DICE approach, but without training. So over about 5 to 6 screens, we ask them questions, they give us answers, and then based on what they tell us, an algorithm is running in the back, selecting from about 1,000 strategies, and they get what we call the DICE prescription. And it actually gives them some strategies to try at home, both for the person with dementia, the caregiver, and the environment. And what's nice about this script is they could either email it to their physician, or they could send it to their family members, or they could print it out. So as I say here, that's nice, but does it work? We did a little pilot randomized control trial, and what we found was that use of the tool significantly reduced caregiver distress. And the design of the tool was that this was the group that immediately got the tool, so you can see they had this immediate reduction in distress. This was a waitlist control group, so they were sort of hanging out here around this level of distress, and then they got the tool, and they had their significant reduction. And so caregiver distress is actually the variable that's associated with a lot of poor outcomes in dementia. It tends to drive use of emergency rooms and nursing homes, because when caregivers get distressed, they decide, I can't take it anymore, and that's when some of this utilization occurs. So this is a very important early signal. We now have funding to test this in about 300 more people, so we're excited about that. And we're trying to partner with various companies to try to sort of get this out onto the market so that people can use it. This was just some of the qualitative feedback we had from the tool. One that is poignant is, I wish I would have had this a long time ago. Many people didn't want to give it back. We also got the response from one person, my spouse had a urinary tract infection. The We Care Advisor helped trigger that in my mind something was wrong. They saw the doctor and were able to get it diagnosed more readily. So it's very positive feedback. So I'm going to stop there. I'll just summarize to say, I think we've talked at length here about how behaviors are universally experienced by people with dementia and have a big impact on all spheres of their life. and that how we currently treat them is largely a mode of sedation. It lacks personalization and precision, and we're trying really to come up with new models that will help people like DICE and the We Care Advisor. And although I am leaving for California in July, we do have some donor funding here that we are going to continue a DICE program here at Michigan. So we're very excited about that. So I'll stop there. Thank you. Any questions?
Yes. So if you have any question, please speak in the microphone so that we can.
Thank you. Is any of this available to the public, like the We Care Advisor?
So the We Care Advisor is not yet, but the DICE manual is. That is available both on University of Chicago Press website and Amazon. And our caregiver website should be out, like I said, in a couple of weeks, and that is directly meant for caregivers.
Is that online going to be free, or?
No, because we have to maintain, it's a very low cost. And it's funny, somebody sent me something today. There's a famous dementia care person, Teepa Snow, and I saw she charges $80 for a 4-hour session. Our website's going to be a 1-year subscription for $69.99, but it's going to include the book and the use of that website for a year, as well as a worksheet that people can use. And that's mainly so we can, there's the cost of maintaining a server and that kind of thing and kind of keeping things up, but we've tried to keep it as low cost as we could.
Thank you. With hearing and
Yeah, so that is a really interesting story. I was part of the Lancet panel on dementia care, which was a worldwide panel of experts, and we had one gentleman that studied hearing, and what we aimed to do with that was come up with the biggest risk factors for dementia that would be potentially preventable, meaning we don't have any kind of medication cure right now. So what are some of the things that we could reduce in our everyday life? And we always hear about things like hypertension and obesity. Those are associated with dementia. Hearing loss was the biggest risk factor. And so we kept checking it and rechecking it because we were so surprised. And what we think is that it's probably a twofold thing. There's probably an impact on some brain circuitry that's associated. But beyond that, if you think about hearing loss, once people start to develop hearing loss, they become isolated. And we know that loneliness and isolation are also associated with cognitive impairment. It's sort of like use it or lose it. So if you're not talking to people, if you're not engaging, that seems to hasten a process. And so there's a lot of interest now and a number of studies being done. Okay, if people have hearing loss and we ameliorate that with hearing aids, will that decrease that risk? But it'll take a while for those studies to be available. And interestingly, I was just in Florida with my parents, and my father is hard of hearing. Now, he doesn't have any cognitive impairment, but I observed this phenomena every time we went to a restaurant. He wouldn't wear his hearing aids, or he'd forget, he doesn't want to wear them, and then he's left out of the conversation. Or he hears part of it and he mishears it, and then people are like, huh? So I think the biggest message there is that possibly there's something there with isolation and being sort of left out that may be really important. And I think as hearing aids get better, hopefully people will be encouraged to wear those. And people who already have cognitive impairment, we also know that if you don't wear hearing aids, sometimes they can even develop hallucinations because the brain seems to compensate in funny ways. So you might have like an auditory hallucination of something. And so wearing those hearing aids seems to be a really important thing. And again, not everybody wants to do that, but I think if you sort of talk to them about how it could be linked with, everybody's worried about losing their memory, right? So if you talk to them about the link with cognition, I actually put on my dad's mirror our study findings and said, the Lancet panel wants you to wear your hearing aids. So hopefully that'll work. My mom will let me know. Any other questions?
So I have a question regarding the randomized trial that you guys did. You said that was a small study. Do you guys have a plan to do it on a bigger study and
so
see
we
whether?
just got funded at NIA to do a trial in 300 people. So that was 30 dyads in each group. And so this is going to now expand to 300. And what's going to be nice about that is it's going to be a much more diverse sample.
Exactly.
Our
that's what I
first
was-
study in Ann Arbor, some of you in the audience may know, we have a very educated town. And so many of the people that we looked at, had a college education or over. So, we want to make sure we get a diverse sample so that we know that the tool, which was designed at a specific reading level that was meant to be easy for people to read, is useful for everybody. And so we want to look in that diverse sample. The other thing we want to do is we used telephone prompts in the first study. We had a nurse that was calling them on a weekly basis. Now, she didn't do any intervention with them, but she just saw if they were using the tool or not. We want to see if that's necessary. So in this study, we're going to use, some people will get the nurse prompts, some people might get an email, some people might get nothing. And so that'll give us more of an idea of what kind of support do we need to give people to use the tool and how useful it'll be.
And do you imagine also that there will be some sort of like tapering in the decrease of, so you showed that there was a decrease in the discomfort level, right? And then I'm assuming that after a while people get used to deal with certain situation, and so there is probably going to be a tapering in the benefit that the tool gives.
Yeah, that's a great question. This will be a longer trial, so this was just a month.
Right.
That was all we could afford. But in the longer trial, we'll be able to see how that's used long term. Our hope is that the tool actually, one of the qualitative feedbacks is that people actually learned from the tool.
Right.
That, for example, they didn't know how to assess pain before, but now they do. And so after a while, that process might even become more automatic. Many of our good caregivers who are very intuitive, they do these things naturally. They don't need a tool. But maybe after using the tool, people that aren't as intuitive begin to do it automatically and they don't need the tool. So those are the kind of things we'll be able to see looking at utilization and all the things in the back of the dashboard. But that's a great question.
Other questions?
All right, well, thank you for your attention. That's a good question.
Thank you, Helen. And as I mentioned, we're going to have a day-long symposium on May 29. Yes, and we hope to see you there. Thank you.